It's an honor for me to be invited today, and I thank Klaus and his colleagues for organizing this conference and for inviting me all the way from Los Angeles. And I bring you greetings from what has to be, even among liberal welfare states, the outlier country. And that, I think, will underscore a lot of the things that I am talking about today. I will start off just very briefly because I know that the great majority of you are very familiar with these data. A review briefly of a few indicators of health inequalities between the United States and other countries. Then focus again briefly on health inequalities within the United States, the role of income, race and ethnicity, which in the United States is a major social stratification category, and other social determinants, and then move on to talk about public health in the U.S. and its relevance to the social determinants of health and to changes in health policy and broader welfare policies going on right now. The United States spends more, as I know you know, on health and health care than any other country in the world. In 2007, we spent $2.2 trillion. That would be approximately, I think, about €1.5 million euros. $7,421 for every person in the United States on a per capita basis, which is about 5,000 euros. 16% of our gross domestic product. What is unique about the United States is its complete inability to control the rate of growth in that spending, which is expected within the next 5 to 7 years to reach 20% of our GDP, which is, I think everyone will agree, a fairly unsustainable level of spending. But despite all those expenditures for health and health care, the United States gets less in return in terms of health, the health of its population. So if we look at life expectancy compared to other OECD countries, we see that the United States life expectancy is 4 years shorter on average than would be expected given the level of health expenditures. But it is not only unequal and getting poor value with respect to its health expenditures, it's also getting low value with respect to its income. If we look at per capita income in the United States, we find that the health of people in the life expectancy at birth of Americans is 3 years shorter than one would expect given the per capita income in our country compared to other OECD countries. And life expectancy at birth has fallen in the United States from 14th in the world in 1980 to 23rd in 2003. And infant mortality has fallen even faster in the United States. In the United States, we are 30th, actually 31st in the world in terms of our infant mortality rate. We rank in 2009, and this is according to a very reputable and official source, the Central Intelligence Agency of the United States, which publishes these data. The United States ranked 31st in the world among countries with populations of 500,000 or more, down from 14th in 1980 and 23rd in 2009. The gross inequalities that we see between the United States and other countries are highly prevalent within the United States as well. Differences related to people's life conditions. Here we look at infant mortality rates across the 50 states within the United States, and we find a gap of more than 2 to 1 between the lowest 10%, averaging 4.7 infant deaths per 1,000 live births in 2004, compared to the 10% of the states with the highest rate, over 10%. And that gap has remained consistent over time. So even though we have seen some improvements in the better off states, the worse off states have improved barely at all, and the gap remains significant. Infant mortality rates vary across the states, as you can see here in this map, but it's not only the total infant mortality, which some might say, well, that has a lot to do with the proportion of each state's population that is comprised of populations of color. African Americans or blacks, Hispanics or Latinos, American Indians. But even if we look within those ethnic and racial groups, we see tremendous variation. The white infant death rate in the United States by state varies from 3.4 in the District of Columbia to 7.5 in West Virginia. Note, however, that the black infant death rate varies from by more than twice that, but from a low of 8.6 in Oregon to a high of 17.2 in the District of Columbia. And please note that the lowest infant mortality rate among whites is found in the District of Columbia, and the highest infant mortality rate among blacks is found in the District of Columbia. Talk about inequalities. Here we see life expectancy variation across counties in the United States, and just these selected counties have a life expectancy gap difference that varies by nearly 15 years. So that if you were born in Bennett County, South Dakota, up in the middle upper part of the country, your life expectancy would be 66.6 years. But if you were born in Montgomery County, Maryland, right outside of Washington, D.C., your life expectancy would be 81.3 years. Those differences are, of course, due to tremendous differences in social conditions and characteristics of each of those counties. They differ dramatically by the percent of the population living below the official federal poverty level, by the median income, by the proportion of the population that has had a high school education, by the proportion that graduated from college and has a baccalaureate or higher degree, as well as by the proportion of that population that is white versus African American or Hispanic or American Indian. And we see even within the Washington, D.C. metropolitan area, shown here, tremendous differences, with gaps as large as 9 years between people born in one community versus another within the Washington, D.C. area. Very substantial differences in these life expectancies. Geographic differences are related to the differences in race and ethnicity, income, education, and other social factors. And often in the United States, there is a tendency to simply associate poor health with being a member of a population of color. The assumption is that people of color, blacks, Latinos, Asians, or American Indians, may have poorer health in part somehow associated with that racial and ethnic characteristic. But of course, there is nothing inherent in being black or Latino or white that could account for our health status. Very few genetic factors that are truly related to race and ethnicity. Rather, these are the association of race and ethnicity in the United States as a major form of social stratification to other social stratifying opportunities and elements in the society. Education, income, full employment, living in certain kinds of communities. So, the income inequalities in the United States and in the social determinants of health as well are more pronounced in the United States, the outlier liberal welfare state, than they are, I would argue, in most of the rest of the advanced economies in the world. Here we see the Gini coefficient, a measure of income inequality among the countries. You can see the United States' place at the bottom of that with one of the highest income inequality measures among all of these countries, exceeded only by Portugal. And the U.S. poverty rate itself, that is the proportion of children living in poverty, is is more than 20% of all children in the United States. That is a rate that is 9 times that of Denmark. So the United States has tremendous inequality in its income and in its, and if we look at changes in income distribution over time, we find that the incomes of the wealthiest 20% of households have grown dramatically over the last 3 decades, but the bottom 80% have not increased. And in fact, one can make a strong case that the bottom 10% have seen their incomes decline, their real incomes decline during this period. Well, how does the public health infrastructure and system respond to these kinds of facts about our society? Clearly, there are powerful effects of social determinants on health, but the United States public health system, and I think in this respect it's probably not that dissimilar from Northern European or other EU countries. The U.S. public health system has a very strongly technical and individual focus. Public health leaders talk about social disparities and increasingly social determinants. And I say public health leaders, I do not mean national policy leaders. But there is not much action that follows from that. The talk has been stimulated by a report of the Institute of Medicine that more than 20 years ago now argued that the mission of public health is to assure the conditions in which people can be healthy. And by that, they included the social conditions as well as the physical conditions. They put an important emphasis on that, but that has not seeped in to the broader public health dialogue very far in the United States, which has been mostly focused on programmatic interventions to address health concerns and disease using technical and individual approaches. The focus is on disease surveillance and on individual behavior change. And to a large extent, I would argue that the U.S. public health system is formally highly competent. For example, the Centers for Disease Control and Prevention, the CDC in Atlanta, is one of the leading such entities in the world and represents a leadership role in much of the world on infectious disease control. But it has a weak infrastructure if you look at the rest of the system. Out of the $2.2 trillion that the United States spent in 2007, less than 5% of all of that money went to formal public health activities of any kind, public, private, federal, state, local. A chunk of it was spent by the federal government, the largest share perhaps, on research, on public health surveillance in support of the CDC, which includes collecting data on infectious diseases and on the chronic diseases of the population, on setting formal standards and guidelines with formal bodies that are designated and officially recognized as the sources of gold standards for what public health ought to be achieving in the United States. And on money spent on public health by the federal government amounting to less than $6 billion in 2009 altogether. Compare that to the National Institutes of Health, our primary funder of basic and applied biomedical research. That got $29.5 billion in 2005. So I think that suggests the broad directions that these components of our health expenditures take, and it may begin to offer some suggestions about why the United States has such low overall public health outcomes compared to the rest of the world, and why we have such tremendous disparities within our country. But there's more to the story than that. In the United States, the federal government doesn't actually do public health. It coordinates and supports public health throughout the rest of the country. Public health is really organized at the state level, which each of the 50 states issues its own regulations and standards, many of them simply adopted from federal guidelines. They are the vehicle for funding of public health programs within their states to a large extent. In a few states, they actually deliver the public health services at the local level. And they have tremendously varying levels of technical competence and strength. I come from a state with the highest level of public health competence in a technical sense in the United States, California. There are not more than probably 4 other states that might match California's level of technical competence. At the other end of the spectrum, you have states like Alabama and Mississippi, and even Texas, with relatively low levels of technical ability. But the primary deliverers of public health service are at the local level. We have thousands and thousands of local public health departments throughout the country, and they vary tremendously in their competence. Again, from at the high end, counties like Los Angeles County and New York City health departments, down to, in California, a very small county in Northern California on the coast with a population of about 140,000 people that has 1 half-time public health officer serving that county. And they are the ones who deliver the services. There's tremendous weakness, as public health leaders recognize, in our local public health infrastructure. Despite all of that, the United States has had experience with a successful macro-level public health campaign, and that is our anti-smoking campaign. This shows the number of cigarettes consumed in the United States over a span of about 100 years. But look at the second bullet, which shows how smoking rates among adults fell from 42% in 1965 to 21% in 2004, and down to 14% in California. This, of course, was no accident. It wasn't simply a secular event that was going on here. It was a very deliberate campaign organized by public health leaders throughout the country. It was a multifaceted campaign involving education of the public policy changes that were very important, in particular, imposition of increased taxes on cigarettes and restrictions on smoking and on access to cigarettes by underage children. And here are a series of events that occurred which helped shape that curve and brought down the smoking rate in the United States in a very deliberate way. During World War II, smoking was actually promoted by the U.S. Armed Forces when they gave cigarettes to soldiers in European theater and in the Pacific. But starting in 1964, there was a very strong campaign, a courageous one at the time, to take on the tobacco industry in the United States and really drive down smoking rates. And it proved to be very effective, but it was a combination of these different strategies: education and policy change, leading ultimately to cultural change, so that today in the United States, as I think increasingly in Northern Europe, smokers are considered pariahs and feel themselves to be excluded and stigmatized for their smoking behavior. So the United States has the capacity to engage in important public health campaigns and change broad kinds of public health indicators and outcomes. But first it takes a public discourse that will focus on these issues with scientific support and policy support to make it happen. That is in its earliest stages in the United States with respect to the social determinants of health. The discourse on health inequalities, as I mentioned before, has in the United States historically focused first on issues of race and ethnicity, a very important form of social stratification. Recent examination by public health scholars and leaders, however, has begun to add an emphasis on the broader social determinants of health. And there has been discussion about inequalities in income and wealth, and about inequalities in the broader social and physical environment. But interestingly, this whole emphasis on health inequalities can be traced back to Ronald Reagan's administration. And for those of you who aren't familiar with Ronald Reagan, he was, well, except from the movies, he was a very conservative president, and he's associated, his presidency is associated with really launching the almost 30 years of conservative social policy we have had in the United States. But under Ronald Reagan, his head of the Department of Health and Human Services, Margaret Heckler, formed a task force on the health of black and minority populations in the United States. And although there was a lack of sufficient data on many population groups, and therefore a primary focus on black Americans, the report was a landmark report that publicized significant differences in health status and access to care by race and ethnicity, and made reference to other factors as well. Under Bill Clinton, this issue was greatly elevated, and it became national policy to combat, as the phrase is used, disparities in health and health care in the United States. Led by Surgeon General David Satcher in the United States under Bill Clinton, all federal agencies adopted priority populations that they were to focus on to try to reduce disparities in health and to do so within a broad policy frame. That included the National Institutes of Health, and it included the CDC and every other federal agency. This led to a proliferation of research studies and Institute of Medicine reports focused on disparities in health and health care, trying to first document these disparities broadly and then to try to identify the pathways through which these disparities occur and actually affect people's health. But the solutions that were recommended out of all of these studies and reports typically focused on improving the distribution of health services to close gaps and to target health education outreach to vulnerable populations that had high rates of chronic diseases, diabetes, asthma, heart disease, and cancer. These were the factors associated with these kinds of disparities in the discourse in the United States. An important discourse, an important change, an important national policy, but yet really insufficient. U.S. public health and national health policy continues to address these kinds of disparities through technical and individual approaches. And it does not really bring into the analysis the social stratification or social inequities in our country. Nevertheless, there is beginning to be a focused public discourse in public health and in health policy circles on the social determinants of health. There has been descriptive research on inequalities in health and healthcare, very strong in the United States, but several private philanthropic foundations, major ones with very broad influence in our country, are focusing on the social determinants of health. In fact, spending all of their resources on targeting those social determinants. There is a consensus strategy that has emerged among, I think, public health leaders broadly in our country to attack the problem of obesity by changing the social environment, primarily targeted to poor neighborhoods in states and communities throughout the country, but also through public education programs. And there is now a public policy discourse on social inequalities that has just emerged out of these same foundations, but it is far less advanced than in the northern countries in the EU. Because I think of your very long tradition and welfare institutions and systems here that have made the elimination of social inequalities a national policy, if not a reality. Just to give you a flavor of this, the Robert Wood Johnson Foundation established a new commission to build a healthier America, they call it. And it is deliberately trying to change the public discourse on these issues, to show that social disadvantage and health disadvantage, and this is a quote from them, accumulate over time, creating ever more daunting obstacles to health. They note that this will require broadening the context of this discourse to include social and economic well-being. And they focus particularly on public policy. You can find information about their commission and about this effort on the Robert Wood Johnson Foundation website. The Annie E. Casey Foundation is a foundation devoted to vulnerable children. And they take a broad focus on the social determinants of children and families and aim at changing neighborhoods and changing policy. Annually, they publish a Kids Count book, data book, with data on all 50 states about issues of education, poverty, and health affecting children. And in California, the largest health foundation in our state, and one of the largest in the country, the California Endowment, has emphasized a new tagline that reads, "Prosperity depends on our health depends on where we live." I put the emphasis in. And this represents the focus of this foundation's programs, spending what will amount to probably $1 billion on 14 communities over the next decade to try to create models of social change in those communities that will lead to improvements in health outcomes in those communities. Whether that's a good strategy or not is open to question, but the important thing is that this is a public discourse and an emphasis which is being launched and led by these major foundations. But some local health departments also are joining in this focus on social determinants. To give an example, also from California, the Alameda County Public Health Department, which is in a large county with a population of well over 1 million people east of San Francisco, has developed a major focus on health and social equity. And they use analytic tools to put a focus on that, create public awareness, and bring communities into that dialogue. They use community organizing approaches to address public health issues. These efforts are serious, but they're in their infancy, and they remain insufficient. The efforts are local, but macro changes are needed to redistribute income and expand meaningful employment and alter culture to support health. There is, however, a window of opportunity in the United States today with the election of Barack Obama as our president and a Democratic majority Congress. There is broad political agreement in the United States covering not only Democrats, but Republicans, business leaders, labor leaders, and the general public, that our healthcare system is broken. We have 47 million people who have no health insurance at all, and an additional 25 million people who have health insurance that is inadequate to protect them and their families in the event of a major illness. In the United States, unthinkable in Europe, medical bills are the leading cause of personal bankruptcy in the United States. It is not unemployment. It is medical bills. And much of this relates to the very high cost of health care in our country, which I mentioned. But there is also a broad recognition now of very uneven and often poor quality of care, with a spotlight shined on this issue by major studies funded by federal agencies. Relatively poor health outcomes of the population are also mentioned, but the primary emphasis in this reform discussion is really on healthcare organization, financing, and healthcare services. So the focus is on expanding coverage, controlling costs, and improving quality. Improving population health is included, but it is sadly a minor focus. President Obama, throughout his campaign and since he has taken office, has made a very public and formal commitment to making health insurance coverage affordable and accessible, reducing costs of care by improving quality and changing payment mechanisms and systems, and improving health outcomes. The Democratic leadership in the Congress is also generally unified around this reform direction. But the emphasis is really, again, on expanding health insurance coverage, modernizing our financing and payment system, and improving quality. Very nominal commitments only to improving population health. So, in this context, however, there still are some opportunities for changes in some of those, at least economic determinants of health in our country. One of them is that the anti-redistributive tax policies that have been a major factor in our country in increasing income inequalities, from President Bush through, from President Reagan through President Bush, are being attacked. And one of the things that I think is very encouraging is that there is weak political support for welfare policies based on individual responsibility, returning to the period before these social programs were enacted. And that's true despite the lack of a significant welfare state development in our country. President Bush, the second, failed to win support for privatizing our Social Security system and creating individual investment accounts, despite 7 years of his political attempts to do so. Medicare, which is a social insurance program that covers all of the elderly in the United States, though not very many people below that age, and has done so for over 40 years, that is considered sacred in American politics. It's called the third rail of American politics, and politicians are warned that if they touch Medicare, they will die. And typically, they have tried to stay away from that, but they have very gradually introduced attempts to privatize Medicare partly, but only at the margin. Education is seen as a vehicle for social mobility and economic vitality, but public education in the United States is seen as failing and needing significant reform. The economic collapse exposed the weaknesses of our unfettered market policies to the general public as well as to political leaders. And there have been widespread demands for re-regulation of financial markets and for a more activist role of the federal government in regulating markets and shaping economic investment and development. These are policy proposals of Obama and his administration that have very broad support. Helped along, of course, by this economic collapse we have all experienced worldwide, and again, as in many things, unfortunately, that get inflicted on Europe, the United States has been the leader in the economic collapse as well. But our own very revered former U.S. Federal Reserve Board Chairman Alan Greenspan publicly announced, as the economic collapse occurred around him and our country, he said, talk about understatements, I found a flaw in the ideology of unregulated markets. But his admission was very important in sealing the end of policies that could simply leave the marketplace unregulated, particularly in the financial markets. President Obama's agenda, I think, does represent a major shift in U.S. economic and welfare policy, restoring some elements that had been deconstructed from Ronald Reagan to the second President Bush, but instituting new ones as well. Adjustments to the tax policies to make them more redistributive, increasing taxes on the wealthiest Americans and decreasing taxes on people below that level, and especially at the bottom. Regulation of financial markets and economic policies deliberately designed to develop green industries in the United States, and even to rein in globalization while remaining committed to open markets. Healthcare reform. I talked about it as limited to financing into healthcare services and organization, but that is nevertheless redistributed, particularly if we bring reliable and sustainable health insurance coverage, adequate coverage, to the lowest segments of American society that haven't had them, and even to the middle class, which has been losing them. And all of that after just 100 days in office. So this is a campaign poster from before the election, but it does represent, I think, the continuing hopes that many Americans place in Obama today. And I would say that these policies have a very significant chance for being enacted and implemented because, and I say this not just because I have worked on the Obama campaign, but because I have been an observer of American politics throughout my adult life and an active participant in it much of the time. And I would say that Obama's political strategies are more thoughtful, more focused, and have a greater opportunity for success than any of the Democratic predecessors, which we have had few of in the last 40, 50 years in the United States. So I share the hopes of many of my fellow Americans that we will see these reforms and that these will have at least a spillover effect in improving health, in addition to beginning to improve some of the health care indicators in our country. Thank you.